Hey there, guys. This is Dr. James Harrington. I'm one of the emergency medicine faculty at the OSU Emergency Medicine Residency. And today we're going to talk about dizziness. There's a few quick objectives I think we need to go over. Number one, we're going to try to get you ready for boards. And really, the only things I think that are relevant here are going to be the relevant anatomy, both peripheral and central, and then a good basic differential diagnosis for the dizzy patient. From a clinical perspective, this is actually a very complicated patient. So I think it's important you know a good differential diagnosis when you get out on your clinicals. This will actually make you look really good because this is not an uncommon patient, and these are very difficult even for seasoned attending physicians. In context of this, you need to know how to do a good history and a good physical. And the history includes knowing the appropriate triggers or knowing the associated triggers and timing for different kinds of dizziness. You need to know how to do a HINTS exam. That's increasingly commonly, that's the exam that we do to try to differentiate central or like a stroke-like cause of dizziness from a peripheral cause like BPPV or benign paroxysmal positional vertigo, which is not as concerning. And then you need to know the associated testing for dizziness. What kind of test do you need to order in a clinical scenario? And this is going to be moving into when you are an intern or a resident. You're going to be in charge of treating these patients. So the dizzy G, like I said, this is not an uncommon patient. And unfortunately, it's not without its frustrations. If you ask most attending physicians who their least favorite patients are, they'll say the dizzy G, which can be short for grandparent if you're kind, or Gomer if you're sarcastic and jaded. But the reason that these are difficult patients is because they're complicated. They tend to be old, they're dizzy, they have a high risk of falls, and there's a whole host of things that could be causing their symptoms, ranging from primary cardiac problems to primary central problems like stroke, to nothing acute. Simply, they're getting old. So moving on to the things, like I said, I think that are kind of high yield for you guys. What's the basic anatomy associated with balance? Well, one of the things is vision, right? If you can see, then you can to some degree orient yourself within space, and that helps you maintain your sense of balance and stability. What else? Well, proprioception. Remember, your hands and your feet give you some sense of this. Your vestibular apparatus, your cerebellum, this is kind of a processing center, and then your brainstem, particularly your pons and your medulla. So remember, your proprioception, your vision, and the information from your vestibular apparatus all meet in your brainstem. This goes into the cerebellum back out. Cerebellum helps process this, particularly your movement through space, and then this gets redirected to higher thinking centers up in your cortex. But when we talk about dizziness, we're really primarily, most of us, talking about vertigo. And the primary organ that governs this is your vestibular apparatus. So the semicircular canals, the utricle, and the saccule. So we're going to try to focus on this, and then as well as the brainstem, because that's kind of the site for scarier things. And I think it's important that you have that in the back of your mind. Let's move on to the vascular distributions associated with this. So when you look at this organ, this vestibular organ, the primary source of blood flow here is the anterior inferior cerebellar artery. And you can see it here that it spits off an artery called the labyrinthine artery. And this goes to both the cochlear apparatus and the vestibular apparatus. So the organs responsible for your sense of dizziness or vertigo, or your position of head in space, and also the cochlea, which is responsible for hearing, right? So if people can't hear, or if they hear a ringing in their ears, this is what's typically affected. In the context of the vascular system at large, you can see that your AICA comes off right here, kind of at the back of this guy. And then this spits off the labyrinthine artery. So any problem along this route tends to cause problems like dizziness and hearing loss and perhaps tinnitus. So this is right at the base of the basilar artery. Realize it sits just north where the PICA comes off on this little man's legs, right? So there's going to be some overlap there, and this will come back. Concerning what the brainstem looks like in this vascular territory, you can see that this artery supplies the vestibular nuclei, the facial nerve, the facial nucleus, and the trigeminal nerve. So this should make sense when we get to brainstem infarctions or pathology in the brainstem, that folks who have a central cause tend to have associated facial numbness and facial weakness. And remember, this can be profound, but this can also be just like a decreased indentation in the nasolabial fold. It can be very subtle sometimes. Also, from an anatomical perspective, it's important to be aware of this site here, the internal acoustic meatus. This is a tight spot through which the vestibulocochlear nerve, the labyrinthine artery, and the facial nerve all pass. So if you think about that, a mass here should cause similar problems to a brainstem problem. However, you're going to get, instead of a central facial nerve problem, right, you're going to have clinically on exam what appears to be a peripheral facial nerve deficit associated with hearing loss, vertigo or the sensation of spinning, and tinnitus. Also, if you think about it, if this mass would push on that artery, you can still get something that looks like a stroke because you're not getting blood flow to these organs. So you can still get chronic problems related to this. And because this area is very small, it doesn't take a large mass to cause lots of problems. But realize this is fairly rare. So this is more just to kind of understand the anatomy than anything practical, because it's unlikely that most of you will actually see a patient with a problem like this. So moving on to definitions. What is the definition of vertigo? Well, the definition of vertigo is the sensation of movement when there is none. Okay, and I think most of us know this, but this isn't all people mean when they say dizzy, is it? People can mean vertigo or the sensation of spinning, disequilibrium or ataxia, inability to walk straight, or lightheadedness, so they feel like they're going to pass out. And this is problematic because it's difficult for us to make a diagnosis if we're going off of this notion that if a patient says dizzy, they mean they're vertiginous, they're spinning. This all came from a study in 1972 that we'll talk about here in a second, but at that time, this was divided into these three categories plus one other that was kind of other, and it typically meant psychiatric problems, with vertigo being associated with vestibular disorder, disequilibrium being a cerebellar disorder, and lightheadedness being cardiac. But in the last decade or so, this notion has fallen apart. So let's briefly go over where this came from and then what studies have shown since then. So the initial study was a 1972 paper by a single neurologist, a guy named Drachman. And this was published in the Journal of Neurology. And in this study, he evaluated, ultimately after exclusions, 95 patients and established diagnoses. But realized that in this study there was no independent verification. And this was done in 1972, which was actually the year that the CT scanner was invented over in Britain. Which means there was no advanced imaging to support this guy's findings. And furthermore, when testing failed to identify a specific diagnosis, the type of dizziness was used to assign a final diagnosis, which is called confirmation bias. He confirmed what he believed without any external validation. Nobody else evaluated the patients to decide if they agreed or not. There was no external testing to decide, was this an appropriate diagnosis? The problem here is this fallacy is propagated by modern review articles. So here's a 2006 article which continues to discuss differentiating the kinds of dizziness based on the complaint or how they describe it. Is it the sense of spinning? Does it feel like lightheadedness? Is it a difficulty walking? But the truth is unfortunately a bit more complicated. Basically, all these things can present as a presenting complaint or a sign or symptom for all the same ultimate diagnoses. These are all ultimately just dizziness. And a couple of studies that I'll mention here, although there are more, include one that was done in 2007, and I believe this was done in the Mayo Clinic proceedings, which demonstrated there was no correlation between the descriptor of the dizziness and the ultimate outcome. So for instance, cardiac causes of dizziness often used vertigo at their initial presentation to describe their dizziness. And The description of vertigo didn't predict who ultimately was found to have a CVA or a stroke. The next year, a study was done which demonstrated that people often use multiple descriptors when allowed to, and furthermore, when they're asked 10 minutes later to re-describe their symptom of dizziness, they tended to change how they described the dizziness. People that started out describing it as vertigo then described it as lightheadedness or disequilibrium. So then how are we supposed to approach these patients? Well, because you're in medical school, let's do a mnemonic, a test, because I know that medical school students are all about mnemonics, right? So a test stands for associated symptoms, timing and triggers, which we talked about in our objectives, examination signs, and testing. So associated symptoms, this can be headache or neck pain. If you're worried about a bleed, right? If you bleed into your head, you can get dizzy, and this tends to be accompanied with severe headache. Ear pain or discharge, which would suggest an inner ear cause. Chest pain, palpitations, dyspnea, particularly if it's exertional dyspnea, if it gets worse when they move around. These can all suggest a cardiac cause. Things like abdominal pain in the young, childbearing age female who may have a ruptured ectopic pregnancy, right? Neurological symptoms, are they numb, are they tingly, are they weak? Okay. These can all lead you in the direction of a certain diagnosis. Next, you need to be asking about timing and triggers. Okay, is it rapid onset? Is it constant? What triggers it? Is it movement or does it happen at rest? That kind of thing. So we're thinking, is this constant dizziness or is it episodic? Is it frequent? Does it come multiple times a day or just once a day, once a week, or once only? Is it waxing and waning? Does it never go away, or is it intermittent, sudden on, completely off? Is it paroxysmal? Does it come and go? Is it positional? Is it only when they stand up or sit down or lie down or roll over? You need to know details about the dizziness. Examination signs. If I can give you any bit of advice about a neurological examination, it's this. Watch your patients, listen to them talk, watch them walk, and look in their eyes. Okay, this is the simplest and most effective neurological examination you're going to get. And if you ever get a chance to read Oliver Sacks, who recently passed away actually, but was a wonderful neurologist, a wonderful science writer, he could glean so much information from sitting in a New York City cafe and watching people walk by. And he describes being able to diagnose people who had symptoms of things like OCD and Tourette syndrome just from watching them walk along the sidewalk. So listen to them talk, watch them walk, and look in their eyes. And if you think about structurally how much information you can get from a patient with this simple examination, you cover an incredible amount of central nervous system territory. A couple other things I think that are worth mentioning. Always check reflexes, particularly in the dizzy patient, and particularly check the patellar and the Achilles reflex, because remember, a lot of times proprioception associated with dizziness and walking has to do with their lower extremity proprioception. Also, take their shoes off. Always check a Babinski's. And when you have their shoes off, you can use their great toe to test proprioception. Now, I feel this is a good point to mention the Romberg test, because we still have the Romberg test on our T-sheet where I work. And I think this is still a fairly commonly taught exam, but there's a great deal of misunderstanding about it, even on sites like neuroexam.com, which suggests that this test is good for vestibular and cerebellar function. These are untrue. The Romberg exam was originally created to test proprioceptive function. It was actually originally used to test for tabes dorsalis, for tertiary syphilis, for the associated proprioceptive difficulties that these patients would have because of their dorsal column disease. The Romberg test is for proprioception. Unfortunately, some patients with vestibular disease and cerebellar disease tend to have abnormalities during the test that are interpreted as positives, which likely explains the poor sensitivity and specificity of the test, but it is worth noting that the test only has a 70 to 80 something percent sensitivity and specificity for proprioceptive problems. So for whatever reason, it is not terribly good at determining the thing that we're looking for. Furthermore, if a patient fails this test, technically the definition is they're unable to stand with their eyes closed, and so they fall. So either you have to catch them and risk hurting yourself, or they fall and risk hurting themselves. But I think it is worth mentioning because it's still a commonly taught test so that you understand exactly what this is. The Romberg test is a test in which the patient is asked to stand at the bedside with their eyes open and their feet together. If they are unable to do this, then the test ends. You cannot do the Romberg test. It's not positive, it's not negative, it was unable to be performed. If they can, then you have them close their eyes. And if they fall, if they're unable to stand with their eyes closed, that demonstrates a proprioceptive problem. Now, people with a severe vestibular problem or a cerebellar problem may demonstrate sway in the front to back direction in some cerebellar problems, and then left to right in others, and the vestibular can be kind of anything. Okay, but they should not fall. They should be able to catch themselves. They just have an exaggerated sway. Another test, if you're going to stand the patient, so for instance, if they have normal proprioceptive function and overall seem to be fairly intact, can include a tandem gait, which means the patient walks heel to toe. And this, again, can give you a great deal of information, assuming the patient is stable enough to stand up and attempt to walk. This demonstrates balance. Okay, you can watch if they sway back and forth, if they have problems speeding up or slowing down, if they can't move their feet around each other well. So there's lots of information you can glean from this test. Once again, assuming the patient is stable to stand up. Moving on to testing. There's really only 4 tests you need to be aware of here. The first is a finger stick blood sugar. Anybody who has neurological problems needs to have a blood sugar checked. These can be exceptionally high or exceptionally low. In a woman of childbearing age, check a pregnancy test. Now that said, what we're looking for is an ectopic pregnancy with significant intra-abdominal blood loss. If these things rupture, women can have liters of blood in their belly, but they will usually come in with significant abdominal or pelvic pain in this case. If they've lost enough blood, they may be unconscious, but once again, you're probably not worried about the dizzy patient in that case. Okay, but it's something worth bearing in mind. Urinalysis, particularly in older folks, so in our geriatric patient population, it's not uncommon to find somebody complaining of dizziness who is ultimately found to have a urinary tract infection, but also realize this is a common misdiagnosis in the geriatric patient who is ultimately found to have a stroke. So make sure you don't just write off their symptoms as a urinary tract infection without doing a good exam. And then an EKG. Remember we talked about cardiac etiology as a possible cause of dizziness. So particularly in the 40 to 50 and up patient, always think about doing an EKG. Now let's move on to definitions. We're going to go to the differential diagnosis, and I'm going to give you a way to group these. Increasingly, this is a common way to group patients who complain of dizziness, and I think it's pretty effective. These are called vestibular syndromes. So vestibular syndrome suggesting dizziness. You can have an acute vestibular syndrome, spontaneous episodic vestibular syndrome, a triggered episodic vestibular syndrome, and a chronic vestibular syndrome. And these are very self-explanatory. There are no tricks here. So let's start with acute vestibular syndrome. Acute vestibular syndrome is the sensation of dizziness that has an abrupt onset and is associated with things like imbalance, nystagmus, nausea or vomiting, head motion intolerance. Remember, the notion here is that it happens relatively suddenly, okay, so within minutes to hours, but it's constantly there. It doesn't come and go completely with head motion, but it can get better and worse. And it may be associated with gait disturbance, and this tends to last for days to weeks and gradually resolve. So what are the causes of this? Well, 95% or more of these in a primary care setting are what we would call benign, which is to say not a stroke. Now, if you go to neurology specialty clinics, up to about 20% of these are found to be a stroke. But realize this has selection bias. This is those who are sent to a high acuity, a difficult to diagnose kind of place. But in the general population, a large majority are things like drug or medication problems, Wernicke's encephalopathy, exposure, so like to carbon monoxide, or metabolic or endocrine problems, or far and away the most common, vestibular neuritis or labyrinthitis. And we're going to get to those in a minute. Okay. About 1 to 4% are found to have a stroke. Now, you have two ways of going about your diagnostic workups, and a lot of this depends on where and how you practice. You can have the worst first bias, and this tends to be our bias in the emergency department. I have to assume that you came to the emergency room because this is a real emergency. So I'm probably going to over-test you, which means I'm likely to do you harm unless this is really an emergency. On the other side of things tend to be folks who practice in clinics, who play the odds. And the odds say that 95 out of 100 times, if I treat this dizziness like a peripheral self-resolving disorder, it will go away. And in that scenario, it's probably not unreasonable to do that. But realize I'm going to teach you from the worst first scenario. And I think it's probably wise to at least mentally train yourself to think through this before you arrive at a more benign conclusion. You don't necessarily have to test every one of these people for a significant problem, but I think you at least have to consider it. So central causes of dizziness. Remember, somewhere between 1 and 4% in a general primary care population, up to 25% in a more selected population are going to have a central cause of dizziness. This can mean stroke, so this can mean the classic thromboembolic stroke. They form a clot in an artery, or they shoot a clot up from their heart, or they have something like a vertebral artery dissection. They tear a vessel, which ultimately occludes the vessel, right? But something happens that causes a problem in the central nervous system. Here's what I really expect you guys to know these next few slides are the symptoms associated with a central cause of dizziness. And I think this is incredibly important to know, both for boards, because they're going to want you to be able to identify this, as well as in real life, because many, and probably almost all medical legal cases involving the dizziness result from somebody not recognizing central symptoms or not considering the possibility of a central cause of someone's dizziness. So this is incredibly important. So realize the problems that can be associated with this are things like dysphagia and dysarthria. They're primary cranial nerve problems. Can't form words, can't swallow well, can't move their eyes around, or they see double when they do. Okay, deep tendon reflexes being abnormal, particularly if you recheck a patellar or an Achilles reflex, it gets stronger with repeated testing. Problems with simple movements, so like a heel to shin, you can see up at the left top of the screen. This is where you have a patient take their heel and run it in a straight line down their shin. Most people can do this, and you can try it. It's pretty simple. But somebody with a central disorder has great difficulty, and their heel tends to wobble all over the place. They have great difficulty moving it straight down their leg. Patients may complain about dropping things, and I recently had a stroke patient, and hers was actually left prefrontal stroke, and she presented with bilateral upper extremity tremor and repeatedly dropping things. But I have seen multiple strokes now who complained that they were having difficulty holding things. All right, they have difficulty with things like finger to nose, so they either overshoot, they overpoint, so they try to touch their finger and shoot straight past it, okay, or they have a lot of wobble when they're trying to get there. Or they may have Horner syndrome, okay, and we'll talk about in a moment why you're going to see a Horner syndrome here. Now, like we talked about earlier, these patients may complain of vertigo, but they may also complain of imbalance. And sometimes, particularly in the elderly population, they may just complain that something's off, or family may complain that their grandpa or grandma is just not acting right. And these are very, very difficult patients because if you see enough of them, you'll realize that lots of times there's not really anything significantly wrong. And as we get older, sometimes you'll experience some delirium, but oftentimes these folks have an underlying problem, whether that's a urinary tract infection or a stroke. It's your job to figure it out. And this can be very difficult to do. So the 5 D's of central dizziness, to make it simple for you, are dizziness. So there's your gimme. Diplopia, or seeing double, particularly on extraocular movement exams. So if you have them look left, right, up, down, right, on one of those, they'll have some diplopia. Dysarthria, or being unable to form words well with the musculature of the mouth. This is different than the kind of stroke you're going to see, like a left MCA stroke, the classic stroke where mom doesn't understand words or can't talk at all, right? This is where they are trying to talk to you, but they sound funny because they can't make their mouth move correctly. Dysphagia, or difficulty swallowing, not painful swallowing, not odynophagia, which is what you have when you have strep throat, but a difficulty swallowing. And these folks tend to aspirate a lot, so they may actually present with an aspiration type pneumonia. And dysmetria, which leads to ataxia. It's a clunky, clumsy movements. And then we also mentioned Horner syndrome. Realize that the sympathetic chain, the first order neurons here, course through the pons and the medulla, which means if this area is damaged, it's going to cause a Horner syndrome. It's going to cause ptosis, so lid, kind of that lid droop, miosis, or contracted pupil, and anhidrosis. They're not going to sweat on that side of the face, although very rarely does a patient with this kind of syndrome complain that they're not sweating on the side of their face. Right? They tend to have all these other problems we just talked about. So, as a review, your 5 D's of a central cause of dizziness, or of a brainstem lesion, are dizziness, diplopia, dysarthria, dysphagia, and dysmetria. And we talked about dysmetria, but I think it is, once again, kind of worth, because you're going to hear lots of different terms regarding movement in like your movement lectures. Remember, this results in uncoordinated movement called ataxia. Okay, causes things like overshooting on the finger to nose. It'll cause abnormalities on your heel to shin. And classically, this is these kind of movements are ascribed to the cerebellum, because remember, this informs the body about predicted distance that a limb will have to move before reaching the intended destination. Okay, and realize that in a brainstem infarct or a problem in the brainstem like this, it's not uncommon that you somehow damage the inferior cerebellar peduncle or the associated connection, so you may get these problems. But in this case, in a just solely brainstem lesion, this may result from a deficit of the spinocerebellar tracts, because remember, if that happens, information can't get from the body to the cerebellum, so you can't get the appropriate feedback that says we've arrived at the destination. And so you overshoot before other senses take over and say, no, we've gone too far, pull back. And so these patients will overshoot and then pull back, or they'll wobble when they're attempting to approach the point that they're aiming at. Okay, so let's move into some specific examples here. There's really only 2 that I want you to know about. These are commonly written about in review articles. These are things you're going to see again and again. You need to know about the anterior inferior cerebellar artery syndrome and the posterior inferior cerebellar artery syndrome. Okay, so we're going to reduce this to really, really simple. And the posterior inferior cerebellar artery syndrome is called Wallenberg syndrome. Okay, now these are most commonly caused by thrombosis of the vertebral artery, so more commonly in older folks here. And that's about half the cases you're going to see in general. Vertebral artery dissection causes about 15%, so about 1 in 7. And this tends to be in younger folks who have brainstem signs and symptoms. So your 30-something who comes in after a car accident with brainstem signs and symptoms tends to be a vertebral artery dissection. But this can be as simple as somebody sneezed hard, or they got scared and whipped their head around. Okay. Occasionally, this can be caused by an embolic occlusion, but this tends to be more rare. So let's start with Wallenberg syndrome because it's named and because all of the symptoms that this includes can be found in AICA syndrome. So this is your umbrella, okay? The basics of Wallenberg syndrome are nystagmus, so that bouncing around of the eyes, right? The vibration of the eyes that tend to be associated with vertigo. And this is usually bilateral horizontal or it can be vertical nystagmus. Okay, vertigo, or the sensation of movement when there is none. Ataxia, so difficulty with movements. And remember, because of where this is, this posterior inferior cerebellar artery, it tends to accompany cerebellar complaints. Okay, this tends to get the brainstem and the cerebellum. You tend to get hoarseness. Okay, so dysarthria and hoarseness, and dysphagia, difficulty swallowing. And here at the bottom left, here's a picture that will review all of the different specific nuclei that are damaged that cause these problems, but I'm not going to belabor that point. Also remember, you can get an associated Horner syndrome with this. And here is the vascular territory here that's associated with this. Do realize there's the vestibular artery right over there. Remember, the vestibular artery can be damaged, particularly from dissection, and can cause problems like this. And in that case, it tends to be waxing and waning kind of problems. Now, moving on to the AICA syndrome, the primary features of the AICA syndrome, remember we talked at the very beginning of this when we were talking about vascular distribution. The anterior inferior cerebellar artery shoots off the labyrinthine artery that goes to the cochlea and to the vestibular apparatus. So this is going to cause hearing loss, possibly tinnitus, and vertigo. Okay, remember we also reviewed this back then. You have your vestibular nuclei, you have your facial nucleus and your facial nerve, and you have your trigeminal nerve. So these are all going to be ipsilateral findings. Okay, you're going to have a single side of the face that's numb, tingly, weak. You're going to have dizziness, and you might have some hearing loss and tinnitus. Okay, remember this is right next door to the abducens nucleus. So you may have abnormalities of the extraocular movements, and this may also catch the sympathetic fibers as they run south. And you may have Horner syndrome. Here is another picture that will show you exactly where that artery runs. You can see how it wraps around the inferior cerebellar peduncle, or the inferior and kind of underneath the middle. And this will show you some of the kind of associated some of the anatomical associations with the artery. You can see how closely this is associated with the PICA, which explains why you will have various associations with Wallenberg syndrome. Okay, this may be only hearing loss and vertigo. This may be hearing loss, vertigo, dysphagia, dysarthria. This may be all of your 5Ds. Okay. Now, like we talked about, unless you go into neurology and work at a specialty clinic, what is far more likely as a cause of an acute vestibular syndrome? It's going to be a problem with this right here, your semicircular canals, your peripheral vestibular apparatus. So most basically, we're going to call this an acute unilateral vestibulopathy. All that means is, just like acute vestibular syndrome, fairly rapid onset, short-lived, one-sided problem with the vestibular system. And this can be divided into vestibular neuritis and labyrinthitis. Vestibular neuritis is exactly what it sounds like. It is a problem with the vestibular apparatus and nerve, and this results in dizziness. Remember, the labyrinth, the bony labyrinth, is the entire space that houses the vestibular apparatus and the cochlea, which means you will get hearing loss and dizziness. If the patient comes to you with this complaint of hearing loss and dizziness and has a headache and a fever and is fairly ill appearing, this is called suppurative labyrinthitis. Okay, typically you have findings associated with otitis media, so a red bulging eardrum with these symptoms. And that means you have infection in the entire labyrinth. Now remember, this is important because over on the left side of this picture, remember, you're touching the meninges here. This is a direct conduit to your brain, which means these folks can very easily get meningitis. which means they need a CT of the brain without contrast to make sure there's no space-occupying lesion, and they need a lumbar puncture. Now, assuming this is not your patient, they're otherwise well appearing, how do you decide is it central or peripheral? Is it brainstem and cerebellum? Is it vascular? Or is this acute vestibular neuropathy or neuritis? Is this a simple, uncomplicated labyrinthitis? We use a test now called the HINTS exam, which includes the head impulse test, a good exam for nystagmus, and a test called test of skew. Now, the head impulse test tests the vestibulo-ocular reflex, which you guys, I think, classically learned about as this exam. If you guys have done any internet searching, you've seen this image, which is usually done in comatose patients to evaluate central brainstem functions. Okay, you can see on the left side of the screen what this is. Basically, this ensures that your eyes move in the same direction when your head moves in the opposite direction. It's not so important that you understand the details here as you understand the fact that this happens and where this reflex relays from and to. So it goes from your extraocular movements to your basically medulla and pons, and then back up to the other opposite eye, right? So this travels through a lot of territory. Now, the head impulse test is basically this exam made for awake and alert patients. And basically what this is HVLA as an exam. You're going to sit facing your patient and tell them to look at your nose. And then you're rapidly going to snap their head from side to side, not trying to break their neck, but trying to overcome their ability to voluntarily move their eyes to look at you. And so they're going to keep their eyes focused on your nose. You're going to flip their head side to side at about a 45-degree angle. And remember here that a positive test indicates a peripheral cause. This is very important. Positive test, and a positive test here means that their eyes bounce back towards you. They have those saccades, all right? What that means is this is a peripheral problem. So this is similar to when you see somebody with a peripheral facial nerve palsy. Remember, they have complete weakness on the entire side of their face that's affected, versus a central facial nerve palsy, which spares the forehead, right? So you actually have less findings with a central cause than you do a peripheral problem. This is the same here. When you have a peripheral cause, you're going to actually see changes on the head impulse test. Their eyes are going to bounce back towards you because that's their vestibular system malfunctioning. Okay, if the vestibular system itself is intact, then you're going to have smooth movements. Okay, or in a really severe one, and this is where you're going to expect them to be unconscious, they're going to have no movements at all, and that gets into the doll's eye, which we'll talk about that in the level of consciousness lecture. But for a dizziness in the awake alert patient with dizziness, a positive test here indicates a peripheral cause. There's a very, very rare circumstance when it doesn't, and I think that's more than we need to get into here. So here's just a quick review of kind of why that happens. Here's the semicircular canals, the utricle, the saccule, and they all go into the vestibular apparatus. All right, remember this is the nerves or the vascular supply here. Okay, we're going to back up and you can see how these all connect bilaterally to the extraocular muscles. So as long as there is abnormal input coming from these, and remember that's what this is, there is abnormal input coming from typically the semicircular canals, okay, and they are coming to the nuclei, or kind of the main computing centers for the eye muscles. On testing, you're going to see abnormal movements. In a central cause, you're not going to see that because you're not going to be getting any information from the vestibular apparatus. Also realize these dive down into the cervical spine. These go to the cervical spinal cord adjustment areas, which create your vestibulocervical or your craniocervical reflex to help you realize where your head is in space relative when you turn your neck. This is just a quick overview of the anatomy. And here's another picture for you guys who are going to go through the lecture that show you where these all kind of relate to each other in terms of the reflexes. So here's the vestibular inputs into those nuclei, and then here are those nuclei again, particularly the nuclei relative to the extraocular movement nuclei, the abducens and the oculomotor. and the trochlear. Here we're going to overlay these on top of the vascular image on the left. Over on the right here, you can see the vascular distributions, particularly of the AICA in dark pink, the PICA, and then some of the penetrating basilar arteries. And then here's the vascular distributions again. These are good to review, and really remember, get comfortable with what sits next to each other. You want to know who are the next door neighbors, so that if one is affected, you know kind of who else to expect to be affected. Nystagmus. We're going to make this really, really simple. There are lots and lots of caveats here. If you read ENT and neurological literature, there are lots of ways that these can go differently, but in general, if you have unidirectional horizontal, so one directional horizontal nystagmus, or sometimes torsional nystagmus, so it kind of rolls, this is a peripheral cause. Any case of bidirectional, so nystagmus when looking in both directions, or vertical nystagmus needs to be thought of as central until proved otherwise. Now remember, this is not always the case, but it tends to be the case often enough that for now I think it's important you think of it this way. Remember, nystagmus is that wiggling of the eyes. You can pick this up on sometimes on extraocular movement testing. Now, if you go to the extremes, so look way, 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 way out to the side, most people will develop some mild nystagmus, but on just regular extraocular movement testing, you shouldn't see this. Sometimes you'll see this when you move their head side to side. It'll exacerbate the problem. And lastly, in the HINTS exam, the test of skew. This, for us, kind of at bedside, is going to be you hold a card up over one eye. This is going to remove their vision from the process of focusing their eyes straight forward. So you're going to have them focus on your eye, and now they can't use that eye that's covered to focus on your nose. So they're trusting on the reflexes to orient their eyes in space on the same thing. So you're going to hold it there for about a minute, and then you're going to remove it. And if you see an eye snap back into position, that means that there's a central problem, right? Because the reflexes that maintain their vision on a point in space are now affected. If you have one of these semi-opaque semi-opaque lenses, you can actually do this without anything. And you can see in the top picture how that right eye starts drifting up and out. Okay, when it loses the ability to focus on anything in front of it. So it's a positive test of skew, and remember that indicates a central problem. Okay, mimics of this peripheral vestibulopathy, particularly acute vestibular syndrome, include metabolic derangements, drug intoxication or side effects, so things like being drunk, right? But carbon monoxide as well. Wernicke's encephalopathy, once again, tends to be associated with alcohol, but we'll talk about it in a minute. It's actually more commonly associated with people who have had gastric surgeries or hyperemesis, so pregnant gals. Meningoencephalitis, most of these folks are altered and febrile. They have severe headaches and neck pain. And then we mentioned environmental carbon monoxide. Sodium, particularly really, really low sodium, so hyponatremia, low sodium, so like in the 1-teens can cause this. Once again, usually these folks are altered. And aminoglycosides, or emoglycosides, right? So aminoglycosides, the kind of antibiotics that they're vestibulotoxic. So folks that have been on gentamicin, for instance, not common anymore, but with all the antibiotic resistances, you may see a few of these. I've for sure seen several of these in the ICU. Most of the time they require the aminoglycoside, and so this is just one of the unpleasant side effects. All right, we talked about Wernicke's encephalopathy. An acute Wernicke encephalopathy is because of a thiamine deficiency. There's really a triad that you need to know, which includes encephalopathy, so acting bizarrely or abnormally, oculomotor dysfunction, so this is where you may see some extraocular movement deficits, but it can also be things like nystagmus, and then ataxia or imbalance. Now, when you think about the people that develop this, about a third are alcoholics and they're drunk, usually for a long time. Anorexics can, because remember, they're globally vitamin deficient. Anybody that had bariatric surgery or any process that would cause malabsorption. Anybody that's chronically malnourished. So hyperemesis gravidarum is one of the big ones, pregnant gals. Dialysis patients, because they tend to lose water-soluble vitamins. And then systemic illness, sepsis, these are going to be your ICU patients. Specifically, encephalopathy can include disorientation, indifference, so they can be incredibly sick. You can tell them they're going to die and they don't seem to care. Okay, you'll also see this with things like necrotizing fasciitis, this labile indifference. say you have very high mortality, you're probably going to lose your leg, and they kind of say, well, oh, okay. And then inattentiveness. Remember, ocular motor dysfunction can include nystagmus, lateral rectus palsy. It's one of the most common palsies you'll see, and conjugate gaze palsies. All right, and then ataxia. We all know drunks can be ataxic. We've watched them stumble and fall around, and there's lots and lots of great YouTube videos to watch on this. So, they have acute vestibular syndrome. Now, what do? You did your HINTS exam. Okay, this is positive or negative, and now you're going to establish the risk based on how old they are, their vascular risk factors, what the HINTS exam said. Okay, how comfortable are you sending them home? Do they need more testing? What's testing going to show? So, if we're worried now, they have a positive HINTS exam, or they're a little older, they have a lot of vascular risk factors, we're worried something else may be going on. If we're worried about a primarily central cause here, you can do a CT, and we tend to do this out of the emergency department because it's quick and it rules out really one thing well, and that is a bleed. Okay, this was actually my patient on the top left, okay, with a pontine hemorrhage. It's actually bulging out the back a little bit. The problem is the sensitivity of a CT for a posterior fossa ischemic stroke is about 15%, so it catches about 1 out of 7 if symptoms have been ongoing for less than 24 hours, which is usually when we tend to see them. And it's when we're most worried about them because there's a thought that maybe we could somehow help them. Okay, you can also do an MRI, we'll talk about that in a second, and then a HINTS exam, right? So the HINTS exam has actually been found to be incredibly sensitive. Probably more sensitive than an MRI or even or a CT or an MRI. Now the CT gets better if the symptoms have been ongoing for greater than 24 hours, but it's still only about 40%. It's still under half. And an MRI is about 80% sensitive, so we still tend to miss 1 in 5. A HINTS exam is thought to miss less than 1 in 50. Okay, so it's got a really great sensitivity. And in the studies where they did this, they found a positive HINTS exam, and then they followed these patients, and at 3 or 6 months, they would repeat MRI them, and they found posterior strokes in these patients at follow-up MRI that were initially missed. So the MRI wasn't great up front. All right, moving on. So let's move down to spontaneous episodic vestibular syndrome. These are recurrent episodes. They develop rapidly, tend to be more rapidly than your acute vestibular syndrome, but remember they tend to develop rapidly and then resolve in minutes to hours. At the most, it resolves in days, and there are no triggers here. Now remember, this can be worse with certain activities or movements, but nothing triggers the event itself. Okay, it happens while they're sitting, sometimes while they're moving, nothing that they can really pin down. And this really can be divided into benign causes, which are either Meniere's disease or vestibular migraine, and serious causes, which is the vertebrobasilar TIA. This is what leads up to a stroke, and this is the dangerous thing you need to be able to identify. So to begin, Meniere's disease is the triad of hearing loss, tinnitus, and vertigo, particularly rotational vertigo. And this is because of a problem with the fluid and ion homeostasis in the inner ear, okay? We're not going to go into details here because unless you're going to be an ENT doctor, this is not terribly important. But you need to be able to identify what this is. Technically, the definition is 2 or more episodes of rotational vertigo that last at least 20 minutes. Okay, remember this is spontaneous. This isn't triggered. With audiometric confirmation of sensorineural hearing loss, this is not a Weber's test and a Rhine's test. Those tend to have fairly poor sensitivity and specificity. This needs to be audiometric confirmation associated with symptoms of tinnitus and or aural fullness. And remember, this tends to fluctuate, so it's spontaneous episodic vertigo. It comes and goes, and nothing in particular tends to trigger it. Remember, the other disease I think you need to be aware of that causes this is vestibular migraine. So these people really, for a primary care doc to diagnose this, they need to have a history of migraines like this. This is not going to be the first time you see a patient like this. This is going to be a rule-out kind of disease. All right, but these folks tend to have typical migrainous type symptoms. So we all know about the scotomas, the like flashing lights that some people will see as a prodrome to a migraine. Some people also get vertiginous with that. They'll get dizzy. Some people get dizzy with the migraine. But once again, they've had headaches like this before. It's always associated and has to be the same as this. Okay, so most of these people have been seen by a neurologist, and they can tell you this feels like my normal migraine. They need medications to make this feel better. There's a vertebrobasilar TIA, and this is the dangerous one that we need to worry about. Remember, this has a stuttering course, which means when they present to a primary care clinic or even the emergency department, they are often asymptomatic. They tend to have normal neurological examinations. Okay? When they do complain, this tends to be associated with other problems, so they tend to have stroke-type symptoms that resolve, right? That's a TIA. So they complained that they were dizzy and they couldn't form words well, or they were seeing double. Realize only about 0.3% of brainstem infarctions have only hearing loss and vertigo. So 20%-ish of all strokes are posterior circulation strokes. About 0.3% of these have only hearing loss and vertigo. So this is rare. The most important thing here is evaluate. So you need to do your HINTS exam just like you would otherwise, and then evaluate for risk factors. Do they have atrial fibrillation, which places a patient at high risk for stroke? They have a history of pulmonary emboli or ACS or valvular heart disease or congestive heart disease. Are they diabetic? Are they a vasculopath, right? Lots and lots of questions. Okay, to review, only 0.3% of brainstem infarctions have hearing loss and vertigo. But dizziness is the second most common chief complaint in vertebral artery dissection, right behind head and neck pain. So if you have somebody with head and neck pain with dizziness, particularly one who just had some kind of traumatic event, however great or small, you need to be thinking about this. But remember, that's fairly uncommon. So overall, if this is all causes of dizziness, and yellow is dizziness that is stroke, so remember that this in the general community, probably a very small proportion, probably less than 5%. Okay, then red, way, way, way down there, is dizziness from a stroke in the brainstem. And green, which you can probably barely see, are the patients presenting with only dizziness, hearing loss, and or tinnitus that are because of a stroke. So it's an incredibly small fraction here. But remember, of all patients with a brainstem stroke, a fairly high percentage have dizziness, all right? And this is important when you read studies on this as well, because some studies will suggest a very high percentage have dizziness. Usually there's some selection bias. They picked a very small percentage of people with very specific criteria, and lots of those folks tend to have dizziness. All right, moving on. We're getting near the end here. So we've got all our different vestibular syndromes. Let's move on to triggered. Triggered is probably going to be your most benign. And remember, get a very good history here. These have to be recurrent episodes. They come and go, completely away. They're intermittent. They develop rapidly and usually resolve in less than a minute, certainly less than about 10 minutes. And they are uniformly triggered. I have no symptoms at rest. I do some specific movement and I have symptoms. And the big one you need to be aware of is benign paroxysmal positional vertigo. This is thought to occur because of stones in the semicircular canals. They're called otoliths. Okay, remember oto means ear, liths means stones, so stones in the ears. These tend to get dislodged and stuck up in one of the semicircular canals, which causes abnormal flow of the fluid in the semicircular canals. Unlike Meniere's, which is too much fluid in the semicircular canals. And this can be diagnosed with the Dix-Hallpike test. Remember, this test is only truly appropriate as a method of diagnosis in triggered episodic vertigo. You can use it in the other kinds of vertigo, but it is not going to make a diagnosis. Okay, you primarily use this to see how somebody adjusts to certain movements. But if you do a Dix-Hallpike in somebody with an acute vestibular syndrome or a spontaneous vestibular syndrome, you are going to misdiagnose them. Because remember, even people with strokes will get worse with positioning maneuvers. What this does do is help you diagnose someone with triggered episodic vertigo with BPPV. And the way you do this is you turn their head to the side at about 45 degrees. You lay them back as demonstrated in the top picture here. And if on one side they have symptoms, then you have diagnosed them with BPPV. Okay? Very, very rarely you'll have someone with bilateral. And once again, you need to be concerned in that patient, but with a unilateral change. And typically it is severe, debilitating vertigo. Okay, the onset is about 5 to 10 seconds after you lay them down, so it's not immediate, and then it gradually resolves if you leave them there. So that's the Dix-Hallpike test. You treat them using the Epley maneuver, which begins with the Dix-Hallpike test. You lay them back, then you rotate their head to the other side 45 degrees, and then you roll them up on their side. Okay, you can look at the picture to get an idea how to do this. This really needs to be demonstrated. But this is what we do, and if you do this multiple times, it will eventually reposition those otoliths, and people tend to have some resolution. They tend to have to do this on multiple occasions across the next several days before they really have full resolution. There's also something called the Brandt-Darhoff exercises. Okay. These will occasionally work if the Epley maneuver doesn't. All right, but you can give these images to patients and tell them, if this helps them in the ER or in the clinic, and they get to feeling better, then you can give them a picture of this and say, keep doing this every time you feel dizzy. And lastly, chronic vestibular syndrome. Chronic vestibular syndrome tends to last weeks to months. Okay, it's rarely emergent, and it tends to be associated with tumors, CVAs, so old strokes, or other CNS lesions like tumors. In older folks, this can be from presbylibrium, so polysensory dizziness. This is basically as we age, our nerves don't work as well, our inner ears aren't as effective, and we tend to get more dizzy. This is why you tend not to see 80-year-olds on roller coasters, all right? Because they tend to get very, very dizzy. Degenerative neurologic disease, psychiatric syndromes, and then drug-related. Things like loop diuretics, alcohol, all right? And then some of the others that we've talked about, long-term exposure to aminoglycosides, things like that. Okay, recap, remember, vision, proprioception, and the vestibular apparatus come together in the caudal pons and the rostral medulla. So the south pons and the north medulla, all right? They interact with the cerebellum to give us both a sense of where our body is in space, our sense of balance and stability, all right, and our ability to move fluidly throughout that space. Remember our vascular territory affected here. This is primarily the AICA and the PICA. Remember that the areas that they affect, remember that they do go on to affect this cerebellum, and so you tend to get mixed disorders. Remember what occupies the different vascular territories. Remember in the AICA, you have the vestibular nuclei, you have the facial nerve and the facial nucleus, and you have the trigeminal nerve. Remember, you tend to get crossed findings with vascular insults and with brainstem insults. So one side of the face with dizziness and the other side of the body. Right? Remember your 5 Ds of a central disorder. Remember your Hintz exam. Right? And then remember your different kind of vestibular syndromes, their differentials. So acute vestibular syndrome includes your posterior circulation stroke, AICA and PICA in particular. Vestibular neuritis or labyrinthitis. Remember spontaneous episodic vestibular syndrome. So remember there's no trigger here. It can be Meniere's disease or TIAs. It can also be vestibular migraines. But these really need to have had previous neurological evaluation. Triggered episodic vestibular syndrome, really BPPV is the only one you need to know about. Remember this, only use the Dix-Hallpike in this group to make a diagnosis. And then chronic vestibular syndrome can be things like old strokes or tumors. Remember, your testing consists of a fingerstick blood sugar. You're going to check a glucose. Pregnancy test on a woman of childbearing age, particularly one with abdominal pain. A urinalysis, and particularly this in older folks who may not be able to complain or may not complain about any dysuria or burning when they urinate, but may have a urinary tract infection. And remember, this can cause a systemic reaction that can cause some of the elderly population to have delirium. And check an EKG, because remember, some of these problems can be secondary to primary cardiac problems, bradycardias, heart blocks, okay, not getting enough blood flow to the brain for other reasons. Remember, a CT has very limited sensitivity in a posterior circulation stroke, probably around 15% within the first 24 hours. And it is even worse in the first 6 hours when, if you believe in giving TPA or the clot buster, this is when you would give it. All right, so it has an atrocious sensitivity. Even after 2 days, the sensitivity is less than 50%. MRI is really your best imaging choice, but remember, it will still miss 1 in 5, so it's only about 80% sensitive in the first 2 days for a stroke. Remember, your HINTS exam is probably up in the upper 90-somethings percentage, so 98% sensitive for posterior circulation stroke, as we know now. Also remember to think about a lumbar puncture, particularly in patients who are dizzy and appear ill. They have a fever, they have a headache or neck pain or stiffness. All right, let's go over a few cases really quickly just to review some of these concepts.